Good morning, everybody. This is our Humanities and Medicine series. The goal of this series is to talk about things that we all use in our daily professional lives, but not we don't think of this as urology. Nevertheless, these are important skills for us to be successful. And what I thought we'd do today is we have a little interactive session. So I would love for participation from our fellows, residents. And basically, we'll go through an exercise of decision making. And I was going to talk of something else, but we had made a couple of difficult intraoperative decisions, and the resident and fellows came up to us said, we don't quite understand how these decisions are being made, and it would be helpful if we have a discussion on it. And so this was prompted by our trainees, and I thank you guys for giving us the suggestion and the feedback, so that hopefully you find this useful. Now, at the outset, I just want to manage expectations. There is nothing in life that's right or wrong. This is all a spectrum, and we can make a decision anywhere along the spectrum. And so this is made on individuals' prior experience and what we have learned during the process. And you can look back at it, and we may make a different decision today, or others may look at it on the same time, would have made a different decision. So please understand that this is just a gray area, and we all try to make the best decision possible. And decision making, we all make decisions every day, every minute of the day. And what we are going to specifically talk about today is intraoperative decision making. We had our faculty meeting this morning, and between our faculty here, we probably have about 100 years of clinical urology experience. That's or more. So that's a lot of years of experience. So what I'd like to do is to open up the group for our faculty, any of them who may be willing to share with us difficult intraoperative decisions they had to make. So these are really real life experience, which I think will be very valuable for our trainees. I open the floor. Any of the faculty would like to comment, please?
Well, I'd be happy to start out. I believe that surgical decisions really come from a lot of experience. However, you can gain that experience. You must understand your limitations as a surgeon and the limitations that you have at the time that you're doing the procedure. And then also when you do any case, expect the unexpected. I was doing a robotic laparoscopic cystectomy in the recent past, and went in to find a frozen abdomen, previous abdominal surgery. There was extensive adhesions. Things just didn't look like they should look. The sigmoid colon was massively dilated right in front of me, actually hiding the bladder and as a female. And so everything was wrong. So I worked to expose the bladder and the uterus, but now it's like 1 o'clock in the afternoon after this, and everything was wrong. And I made a decision to back out, saying that this is not looking right. There has to be some other underlying problem. I had done it laparoscopically. There wasn't much morbidity with doing this. I said, I need to work this person up and find out what else is going on, because this doesn't look right. And plus, she was very obese. To try to do it open would have been just disastrous also. So my decision, and it was the right decision, because then we were successful in doing this at another time within a month, was to back out at that time.
Thank you, Mark. Any of the other faculty would like to make any comments on their experience?
I think consistent with what Dr. Bandic just said is the theme is really knowing your limitations. And every reconstructive case I do has about 3 or 4 plans, because you're never sure what you're going to be able to do till you're in there very often. And so I'm constantly reminding myself of what I think is going to get the best outcome in my hands. And sometimes that's different than what some of the scientific literature may publish. And in my mind, it's just this theme again of knowing what you can do best and applying that to every case. And you know, that's kind of something it's a mantra that's going on in my head during every case.
Thank you, Joe. Anybody else would like to make any comments? In fact,
So, in PCNL, most of the time we have to make some judgment calls, like whether to go for complete stone clearance, whether to dilate the same track, go for another track. Most of the time it revolves around what are the risks and benefits. If I put one more track and dilate, if I clear that stone, I'm increasing operative time and risk of bleeding. If there's a small stone, I can come back and take care of it later, just with the ureteroscopy with the minimal morbidity, or that's going to be another major surgery. The risks and benefits. If the patient is already bleeding, already very limited reserve in that patient, then we try to be quick, just get your job done and come out. Even if there is small fragments remaining somewhere, then we can go back with the ureteroscopy later. Kind of judgment call, educated guess, and the error to be more towards on the safety side. If I want to make an error, I would rather happy to make it on on the safer side than going more aggressive. That is the kind of decision or mentality we need to inculcate. Be on the safer side, you would not regret later.
thank you, Harry. That's pearls of wisdom right there, guys. Safety is everything. Any other comments?
For me, I would say that Dr. Costa's comments are most telling to me, most helpful in terms of having several options. Now, for me, I would say that I try to reduce the obvious outcomes to the minimal amount by trying to get as much information as I can about the patient ahead of time, and so that I have the least amount of big decision making to do intraoperatively. Nevertheless, I know that's not always possible. Sometimes you have to go into a case and not know exactly how it's going to turn out, but you have to have several options. But I guess for me, because of my temperament and that I have difficulty making big decisions like that intraoperatively, then I maximize the amount of workup I do preoperatively, and I want to know everything I need to know about the patient to see if there's anything that is unforeseen that might come up as a surprise during the case. So it has been told of me that one of my previous colleagues, that when I was up in Fernandina Beach, commented to another group of urologists that whenever I take a patient to the OR, when Marino takes a patient to the OR, he needs it because already he's been thinking about it for a long, long time. So it was kind of a joke, but that's my best defense, is to prepare the patient as best as possible so that we have the least amount of uncertainty.
Thank you, Roberto. Any other comments? Okay, I really appreciate the faculty sharing their experience and thoughts. I mean, this is very, very valuable, and we all live with uncertainties in life. It's not necessarily insecurity, it's uncertainty. Both feels the same, but one is very different from the other. So one of the things I just wanted to talk to you guys about, and we referred to this in one of our earlier core competencies, or when we talked about biostatistics the other day. This comes from manufacturing, and this is not very different from the kind of decision making we make. And basically, I want to introduce you to three terms: robust, flexible, and resilient. And the robust and resilient, we'll talk about it in a minute. Flexible is our ability to defer, abandon, expand, or contract. And this is very clear in manufacturing and in surgical decision. The comment that Dr. Costa made was exactly referring to it. He goes in there, he's got, he's as experienced as a reconstructive surgeon gets, but back of his mind, he always has options. You never know what we're going to find, and we have to remain flexible, including just abandon what you went in for, like Dr. Bandik's experience, because there is something that's telling him that this is not the time, maybe there is another time, or maybe there is another way to do it. And so never lose of the sight why you went in there. And if you find something at the time of surgery, this is not, it's okay to come back. Backing out might be the best victory you'll ever have that day. And so just accepting the fact that we may not be able to accomplish what we want for that day is okay. And that's a key thing in intraoperative decision making, is really being flexible, our ability to defer, abandon, or expand. Okay, and that's the key thing with intraoperative decision making. Now, a lot of other decision making that we make, we just want to make decisions when we set our goals, or we set processes in place. We want this to be robust. In other words, robust means that you're trying to get to an endpoint, and then there are a lot of perturbations. This happens, that happens, but our system should be robust enough to withstand this and still able to accomplish it. A good example that's very contemporary is our residency program. Our goal here, we have made a decision that we are going to put out highly competitive, technically skilled, and academically oriented residents. That's what we want to do. Now, during this process, there are always feedback, there are comments, there are things that say, well, we could do better, or this is not working, and so on. We take all this. These are perturbations. Sometimes we are satisfied, sometimes we are not satisfied, but nevertheless, we accommodate all that. But ultimately, we don't lose sight of the fact that we are trying to produce some of the top quality urologists from our residency program. That's just an example that we all can relate to. And the difference between robust and resilience, in a robust, while we're going towards the target, it doesn't throw us off the track. We're still on track. We're just hitting some bumps along the road. Think of it like flying. There are some bumps, but eventually you're going to get to your destination. Whereas resilient is when you're thrown off track. The classic example is when COVID hit, all our volumes plummeted in April of 2019. I mean, we never knew that can happen to a medical practice or a medical system, for example. I mean, we're always busy, we got work to do. And suddenly we found that we had no patients coming in, and we were facing something that we had never seen before. Now, however, we have bounced back again. And that's resilience, an ability of a system to return to its original state or move to a new desirable state after being disturbed. So these are three broad terms I want us to have in mind as we think of decision making. Okay. Any thoughts or questions on this? Feel free to interrupt me, guys. Otherwise, it's pretty lonely giving a talk like this. Now, decision making is a process, okay? So, and we will go through a small exercise in a few minutes where we will use this decision making process. And now, clearly, we don't get a Word document or an Excel spreadsheet every day we make a decision, but fundamentally, this is what is going through our mind. And in this process of decision making, the first step is we have to define a problem. And this problem, we all have to agree, because what we don't want to do is come up with solutions and then find a problem. That happens often. What we really want to do is to identify or define a problem, and then try and work on a solution. So this defining a problem in practice, we have to come up with a one-sentence agreement. It cannot be multiple problems endlessly going on. So we have to narrow it down. And then the second step is we have to determine the requirements. This says, look, in this decision, we must have it. If we don't have it, it's not an acceptable solution to us. So every decision problem should have a must-have. And then we could have goals. Goals are, it is our intent and desirables. They're a little bit different from must-have. We may not be able to achieve all our goals, or we may not get everything that we desire, but we can negotiate, we can compromise on it. And then in a decision process, clearly we have to think of alternatives. Now, I do realize that as I'm narrating this to you, this may sound a little bit esoteric. Nevertheless, when we actually go through an exercise, when we do the intraoperative decision making, you may find this useful. And the alternatives can be finite or infinite. We have to set a criteria, and this is usually goal-based, and the criteria should be discriminatory. So if you have multiple options, you got one option should be different, and the criteria should be able to discriminate between these options. There are several types of decision tools that are available. Then after you've gone through this process, you evaluate the criteria versus the alternatives, and then you validate the solution to the problem statement. So this is clearly a business school talk where you go through this exercise, but it's not uncommon for us to have this kind of mindset so that we understand how we arrive at decision, and there's a method to it. So if our team member asks us, why do you make this decision, or how do you make this decision, then it may be easier for us to explain to them why we do what we do. Now, the key thing in the process of decision making is selecting the right tool. Clearly, each problem is different. Each problem calls for a different kind of solution. One size very rarely fits all, and therefore there are multiple types of decision tools that we can use. And when you open your calendar today, you should have a PDF document that is attached to it, and that's where I got most of this information. Now, this particular PDF document that I've attached, I did not do an exhaustive review of the literature on this topic. I just found this to be useful, so I shared that with you if any of you are interested in this kind of reading. And basically, if you go to colleges and there are graduate level courses on what they call operations research. What this is this is a subspecialty that actually specializes on decision making, because ultimately, decision making, we do it at a basic level in our lives on a day-to-day, but this can be done at a huge scale. And there are processes and tools that some of the pros use to make these decisions. Broadly speaking, these tools can be divided into two categories. One is elementary, which you really don't need great computational power to make those decisions. And the other thing is you need because there are so many variables, so many data, you probably need computational capability to make those decisions. The elementary decisions, we use simple things, a pros and cons method. Should you buy a house or rent a house? You think through it. Do you buy a used car or a new car? I mean, we make these kind of decisions all the time using a simple pros and cons method. Then there are other methods, which is called the maxi-min method or maxi-max method. Basically, these methods tell us just avoid the worst case scenario. As long as it's not the worst case scenario, we are okay with it. We were talking in our faculty meeting today with regard to should we accept insurances that it doesn't pay us well, and we are trying to make a decision. Maybe we will, because if we don't accept, then we are not making any money. So some money is better than no money. So we are basically avoiding the worst situation, which is no income versus some income. So the other methods are called conjunctive and disjunctive methods. And these methods look for satisfactory solutions. When we try and do something, we want the best, we want the top outcome, and so on. That may not always be possible, or maybe the best outcome is not important. What's important is just being satisfied with what you have or with the decisions, and then you use a different tool. Or you could have multiple options that you could do, and all of them are good things. When you can only choose one or two, then you use a rank method, and this is called the lexicographic method. You basically rank them in terms of priorities. And then those priorities might change, but at this moment in time, although all of these are great, we're going to choose the top one or two, because in terms of ranking, that's the best thing. The other the other method that we commonly use in our department is what we call the group decision making. And there are two key requirements when you make group decision making. Is first we have to agree on a problem, and then everybody in the team should be vested in the solution. So this is where engagement comes into play. If some people don't think it's even a problem, then they're more likely to be less engaged. And so in a group decision making, when we, you guys may ask, like we talk about how to do a core curriculum, and it's a group decision making. The first question I would ask you, which almost sounds redundant to you guys, I would say, is core curriculum important for you? And it may sound like a loaded question. What I'm trying to do is, because I'm using this model of group decision making, I want the group to agree, even though it's obvious that is an issue that is important to us. So we agree on this, that once we agree that core curriculum is important, then we also agree we need to improve the core curriculum, and that's the problem we are working towards. And then we want to make sure that everybody is vested in the solution, and that's the best way group decision making. And there's something called sensitivity analysis. We had a long talk on it from a statistical point of view. Bottom line is, we make decision based on multiple factors. Or is it dependent on one or two key factors, or all these factors contributing to it? And that's what sensitivity analysis does. And of course, this is less relevant to us today, but I just want the group to be aware. There are multiple computational methods, group decision making, and all these fancy words in there. And these are more like stock markets and huge financial institutions. They're looking at so many variables. They're looking at so many predictive models. They want to see what the best. And this is not particularly relevant to us, other than for us to know that decision making itself is a huge field by itself. I'm going to play a video here.
Good morning, Coast Guard Sector Boston Command Center. Mr. Fleming speaking.
Good morning, sir. My name is...
A caller reports that a friend...
Hey guys, are you able to see the video?
No, we did not. I didn't see that. I heard audio.
Audio, okay, let me, clearly there is... So let me, okay, I guess I got to. Can you see something like a video here? Yeah, okay.
Yes.
Good morning, Coast Guard Sector Boston Command Center. Mr. Fleming speaking.
Good morning, sir. My name is...
A caller reports that a friend went paddleboarding earlier in the morning, but he's now overdue. The Coast Guard initiates a search with a 45-foot response boat.
Engaging.
Out of Boston Harbor.
Coming up.
Unfortunately, a paddlecraft in trouble has grown increasingly common.
You are required to have a life jacket on. Reason for that is in 2015, I think we had 625 deaths nationwide. A number of those people that were recovered without a life jacket.
The command center also launches another boat out of Station Point Allerton in Hull.
Short disconnected!
Stand clear, wise.
The caller said the missing person typically paddled between Nantasket Beach and Boston Light, about 3 miles away. But with all the unknowns, where he got into trouble and how he may have drifted, the search area could be as large as 20 square miles. Search and rescue operations are often based on unique circumstances and require action despite incomplete information. To attack problems like that, statisticians turn to an idea that originates with an 18th century English clergyman interested in probability, Thomas Bayes. Imagine you're given a coin to flip and you want to know if it is fair, 50-50 heads or tails, or weighted to land more on heads than tails. The traditional approach in statistics and science doesn't assume either answer. and uses experiments to find out. In this case, that involves flipping the coin a lot. Or you could approach the problem like a Bayesian. Unlike traditional statistics, that means starting with an initial probability based on what you know. In this case, all the coins you've ever come across in a lifetime of flipping coins have been fair. Seems likely this one is probably fair too. Next, you also flip the coin, updating the probability as you go. Let's say it starts off with several heads in a row. That might make you wonder, increasing your probability estimate that it's weighted. But as you flip it more times, those start to look like chance. In the end, your best estimate is that it is probably a fair coin. But you are open to any new information, like it belongs to your uncle the con man, Crooked Larry.
Sector 659, our estimated time of arrival is 1158.
Bayesian inference creates a rigorous mathematical approach to calculating probabilities based on new information. And it sits at the heart of the Coast Guard's Search and Rescue Optimal Planning System, SAROPS.
He's been missing since 7:30 this morning, so I'm going to go ahead and do a SAROPS drift.
SAROPS takes information about the last known position of the object of the search.
What's the direction of the wind?
Along with the readings of currents and winds, and combines them with information about how objects drift in the water to simulate thousands of possible paths the target may have taken. These get processed into probabilities, indicated by color, and turned into search plans to be executed.
SAROPS is really a workhorse for the Coast Guard. It does a lot of the calculations for us and provides us with a lot of valuable search patterns and search planning options.
I thought he was pretty far offshore, but he said he was okay, so I kept going.
Word of the search has spread. A boater calls in a sighting from earlier in the day.
What I did is I went in and put that information into SAROPS, and it changed everything.
SAROPS quickly recalculates all the probabilities and generates a new search plan. The area has shifted about 3 miles farther out to sea.
We are on scene, commencing search pattern now.
Keep a good lookout.
Roger, coming up.
We're assessing the situation on scene. Any object you see in the water, please take a closer look at. Paddleboarder, port side.
Roger, we have located a paddleboarder with 01 person on board.
Port border. Port side. I have a visual. All right.
As it turns out, the search has been a drill. Hours earlier, the paddleboard was placed in the water by another Coast Guard ship and allowed to drift. The instruments mounted on it are there to measure wind and record the path it's taken, information that will later be used to tweak the drift simulations in SAROPS. Though the system performed quite well today.
The object was right in the middle of our search patterns. So SAROPS was actually dead on accurate in predicting where we needed to search to find the missing paddleboarder.
To be able to call a family and say your family and friends is coming home is absolutely a call that all of us should have the chance to make. And fortunately, because of stuff like this, we do get to make that call.
Are you able to see my screen now?
Yes.
Thank you. So that was an introduction to this. It's called the Bayesian method. And to me, everything that all our attendings spoke this morning boils down to this fundamental way of decision-making, intraoperative. Basically, it involves basing the decision on probability of a successful outcome, where this probability is informed both by prior information and new evidence the decision maker obtains. And this is what happens in intraoperative decision making. So we base our decisions based on all the preoperative parameters. And then you go in there, and we should be open to this Bayesian method of decision making. And this is what fundamentally drives intraoperative decision making. And so for the trainees, it may sound a little bit unusual. We went in to do this. Why are we making a different decision? And so on. And it is, the Coast Guard video I just showed you, you could demonstrate it. You got data. But when you're in an operating room, it's not very different from that. You're right inside the surgeon's mind. You're trying to feed in all this information and come up with the best decision possible. The key thing here is for us to understand, we came in with the decision that information that we had before surgery. Now we have generated new information at the type of surgery. Does that alter your decision? And is that your decision robust? Is that your decision resilient? Or do we have to be flexible with our decision making? And that's what we are trying to do when we go into an intraoperative decision. What I'm going to do, and I thank Umar for helping me with this video. Before I get started, this is a video of a robotic radical prostatectomy, and before the recording didn't start when we started the case. It started somewhere later. But the position you're going to see, which is just getting under the pubic arch. Normally, when we do this, we are in this place in about, say, 10 minutes, 5 minutes. In a very easy case, we'll be there within 2 to 3 minutes. In a tougher case, maybe 15 minutes. In this case, it took us about maybe an hour or hour and a quarter just to get to this area. Basically, I'm just talking about exposing the Cooper's ligament and getting in. So the patient had extraordinary amount of visceral adiposity. It's like having adhesions, but this is much more complex because anything you touch bleeds, and it's just fat everywhere. And I'm going to play a 2-minute clip, and then we will do a workshop together. So the bottom line is, we have spent almost an hour and a half or so on this, and we're still struggling to expose the prostate, and we did eventually expose the prostate. But it has already taken us almost 2 hours to get to this point, which is unusually long how we do things down here. So we had to make some intraoperative decisions here. And and then remember the tool that we talked about. So I'm just going to get some help from Umar, and then the residents and wouldn't mind participating in this and just helping me out to make a decision. Okay. So remember the tools that we talked about. So we'll come back to this in a little bit. I just want to go through some of this information here. Umar, are you online, Umar?
Yeah, I'm online.
Okay. How old is the patient, Umar?
Patient is 70 years old.
What is the grade?
Grade was grade group 2.
Yeah. Volume of the prostate, Umar?
Volume was, I think, around 60 cc. It was
more like
it was more than that. Yeah, let me just
about
reconfirm.
100 grams, if I remember right. It was a big prostate. I mean, life expectancy, we would put more than 10 years. Any prior abdominal surgery?
Let me just go ahead. I don't believe so. It was all fat. Let me just.
And his anesthesia risk was ASA 3, if I remember right, roughly. Any major medications or any?
No, he did not have any medications that would stop our surgery.
And then BMI?
Well, his BMI was high. It was almost 35. He was a pretty big guy. He was like 6 feet something, and it was really fat. Although his BMI was not really very, representative of what we saw inside.
Yeah. Okay. So now we would just look into the probability, Sumar. Based on your work on men who are 70 years of age with a grade 2 cancer, what is the risk of overall mortality, Uma?
Well, the data that we had exactly for SEER, it was for a patient with 70 to 74 years of age. The overall mortality for patients with localized prostate cancer was around 24% over a median follow-up of 4 years. And then prostate cancer mortality was almost 5% in that age group.
Do we have any data on progression, Umar, for this?
The risk of metastasis in this case, actually, I'm using the data on from the PIVOT study, actually, in which they have done it for patients with. They've divided it between 65 and more than 65. So for them, the risk reduction was 11, relative risk was 0.63. And then the data on, give me a second, just, its progression was, go to that graph again.
Okay, so roughly, Umar, you're right. The difference is about 35 and 15%, but because this is grade 2, it'll be lower. So I think the difference may be about progression by doing surgery. We'll probably reduce it by about 10%.
By 10%, yes.
Yeah, I think that's
what we're looking at.
Now, what is the probability of complete urinary incontinence in general? You may not have this data on here. But where somebody needs an intervention or something like that, in an average case in our hands, probably 2 to 3%, where they're complete incontinence, but stress incontinence is of course 60-70%. It's very high, and the ED in our hands is very, very high. The published literature is all over the place. It goes anywhere from 10 to 80%. So I'm just going to say it's very high, and the mortality risk from surgery in prostatectomy is something like 0.5%. It's very, very low. Okay. The morbidity with this surgery is quite high in terms of urinary incontinence ED, and then rarer complications like rectal injury and so on is again very low, but not unknown. So I'm just going to put rectal injury about maybe 0.5%. Urethral injury, I think, is 0.2%. It's very rare, but not unknown. So as we go into this, these are the benefits we think the patient would have. There's a cause-specific mortality. So what we'll do is, what we have learned is we'll just talk about the difference rather than the actual. By doing surgery, we think we are reducing the overall mortality rate based on the PIVOT data and all that by approximately 3%. And then the cause-specific mortality, we don't save everybody. We're probably improving by another 2%. So by doing this surgery, the difference we are making is decreasing the progression, improving cause-specific survival, overall survival for a grade 2 prostate cancer, somebody with 100 grams. The incidence we think is high. The rectal injury is very low, urethral injury, and there are other things that we don't know about. Okay, if you look at the overall complication rate in our hand, some form of complication, either a long-term hernia, a bleeding, and all that, in our hand is less than 5%. We haven't specifically looked at it, but 95% of the time our patients do well, except for, of course, urinary incontinence, ED, and those are different. Okay, so these are the information that we had prior to surgery, and based on this, we decided to take the patient to the operating room. Now I'll open this up for discussion here for the residents, and any of you can work as a team or you can volunteer. I just request participation. So what we are struggling with this year is we do a lot of robotic prostatectomies here. Most of the time, even with residents doing a significant proportion of the case, we get it done about, we start around 8:15, 8:30. We're usually out of the room by 11:30, 12 o'clock. It takes about 3.5 hours for skin to skin. And here we are about an hour and a half into it. We just about exposed the pubic arch. And now we have realized that the patient is very, very obese. We did look at the imaging studies, but we kind of underestimated the visceral adiposity that we encountered at the time of surgery. So could any of the residents tell us what the problem is and what decision do we need to make?
Sorry, can you ask the last question again? What we should diagnose, which problem?
Okay, so let me then put it. The problem is I'm trying to decide, okay, whether we should proceed with robotic radical prostatectomy. Given the fact that this patient has visceral adiposity, we already spent an hour and a half, almost 2 hours. We are just behind the pubic arch now. Okay, that in my mind, that's a problem. Anyway, that was a problem the team faced. Should we proceed with the question then is, you could make a decision either way, as I talked about. There are so many ways we can make a decision. But at this moment in time, the one sentence problem is whether we should proceed with robotic radical prostatectomy like we planned. Okay, I just want to go through this process, and then we have to determine the requirements. Requirements means certain things have to happen or certain things should not happen. Could you think of any requirements that we should set, that if this requirement is not met, then we should not proceed with a radical prostatectomy?
So I would say in minimally invasive surgeries, if we are not making progress in one plane that is supposed to, for example, last a certain amount, like, for example, 15 minutes to 20 minutes, if we are not making progress twice as long as that, probably we should change our plan, either change our approach or maybe convert the patient to open. And this is across all the things. So I am not aware of details of this case, but you're saying 1.5 hours behind the pubic arch, which is supposed to finish in the first 15 minutes.
Yes.
I would abort this case.
Yes. So some of the requirements that you're absolutely right, Sarosh. In minimally invasive surgery, the clock does not lie, because we are engaged in what we are doing and we are taking one step at a time. But if you look at the clock and it's taking too long, then we know how we work. And that tells us that we are not progressing. In fact, when we started minimally invasive surgery, lack of progression was the commonest reason to convert. Nowadays, it's because we end up having some problem, but that was the thing. So our alternative is to convert to open. The other alternative, in the interest of time, I'm going to move on this a little bit. So the other alternatives for prostate cancer in particular, there are other radiation and other treatment options. We could argue the merit of each of these. other treatment options. Okay, so it's not that surgery is the only thing. Now, in my mind, the requirements was it's always safety. Okay, so no matter which patient we do, we want to be safe. In this particular case, my requirement was avoid rectal injury because, and I'll tell you why. What we have, and I've had, in my experience, I reflected on it as I was driving in this morning. I've had 4 cases of rectal injuries. One was during a cystectomy, and one was during prostatectomy. Early on in my career, and both of these were early robotic experience. But what was common in both these patients is they had very big prostates, and the challenge we had was we could not, and they also had relatively narrow pelvis, so we could not retract the prostate efficiently, and therefore I couldn't tent the space between the rectum and the prostate. And on both occasions, we deliberately incised the rectum and hoping that we would close. One patient did fine. The other patient, we actually did a neobladder following a cystectomy and developed a fistula between the rectum and the neobladder. This was early on in my career. But what I learned in those times was that if you have difficulty retracting the prostate or the specimen for that matter, then the rectal injury, at least in my hand, increases exponentially. Then I went for another 15 years without any rectal injury, and then had another one when I was working at the VA a few years ago. And that, again, very similar situation. I could not retract the prostate, and I inadvertently entered the rectum. So I didn't mean to, I inadvertently. Primary closure, patient did fine. And then I had one rectal injury here in practice about maybe a year and a half ago. And this was inadvertent. I had the same situation, difficulty in retracting the prostate. It was seemed to be stuck to the prostate. I thought I was incising the prerectal, then inadvertently entered the rectum again. I did a primary closure on this patient. He did fine for 6 to 8 months, and then developed a rectourethral fistula. And then I referred the patient to Dr. Costa. Joe, I don't know whether you had a chance to operate on that patient yet, or you left him alone.
I have offered them a repair, which would require a fecal diversion first, and they are not willing to buy in on a colostomy temporarily. So they're thinking about it, but I'd be more than happy to repair them.
Yeah, sure. Thank you, Joe. Appreciate your help. So, and just to put this in perspective, guys, Devonshire recently, I had a new rep who come, or a new business manager we are working with to get that simulator on site and so on. So I told him that we have been doing robotic surgery for a long time. We were the early starters, and so he went back and looked at a number of robot cases that I have personally done over the years. And he came up, he said, look, this is not totally accurate, but this may be the ballpark. He came up with a number of about 925. And so let's assume 1,000 patients robotic for calculation purposes, and I can recall 4 rectal injuries, and maybe I don't recall 1 or 2 because they did so well. So again, it's very, very low. But when I looked at the patients who actually had rectal injuries, in my mind, the same thing happens. Large prostate, unable to retract, and I can see, in my mind, it tells me, okay? So to me, the requirement here is, of course, always safety for every patient. If it's not safe, then just don't proceed. It's not worth it. In my mind, I want to avoid rectal injury. Those are the 2 requirements. And the goals, of course, is to complete surgery in good time. And minimize blood loss, and make it minimize blood loss. Now, the other thing is, we want to, you guys see how we do a prostate. We pretty much spare the endopelvic fascia, puboprostatic ligaments, the neurovascular bundle. We try and spare everything. Sometimes we cannot, but that's our goal, is to do what we call an anatomical prostatectomy. Not because I believe that these things actually correlate well with the outcomes. That's a good way to do it. and hope it correlates with outcomes. It doesn't. It just tells me there are more factors. Okay, we want to. So these are my goals. Now, I'm just going through this exercise because clearly we don't write these things out. So the alternatives here are proceed with surgery as planned. Okay, or you can abandon the surgery or abort. Okay, those are really the alternatives, or accept the complication, accept increased complication rate.
Could I make one?
Yeah, go on. Yeah,
Can I make one comment?
Please.
You have to know before you abort. I don't believe all the time that open is the right decision, especially if you have an obese person. And also the other thing with aborting, you pass the point of no return. Like, for example, in a cystectomy, have you transected the ureters? Then that's your point of no return. In a prostatectomy, it's where you've taken the bladder off the prostate. So you have to make that decision before that point of no return.
Yes, I agree with Mark. Once we did a MRI on a guy with high-risk prostate cancer. They told us the patient had a very prominent median lobe. So when I went in there, I've done tons of median lobe in my career, but this median lobe would not just come out like an adenoma. It was really, really stuck. So when I got into the seminal vesicle area, posteriorly, the tumor wouldn't come up. It was invading all that area. So what the MRI told me was a median lobe was a very locally advanced cancer. So in that case, I had to make an extraordinarily difficult decision. I thought I'd gone through a point of no return, but then I couldn't proceed. And that means I got to resect this rectum. It got very complicated. So I did something I'd never done before, just reversed the surgery. So basically started closing the posterior bladder neck, put a catheter in, closed the anterior bladder neck and exited. The patient post-op did remarkably well. Then we gave him ADT and radiation. And when I last saw him 3 or 4 years ago, his PSA was undetectable. So that was an extraordinary decision I had to make. But the principle that I want to really share with our trainees is, as surgeons, just think of that Coast Guard video. You go in with some information to the best of your ability, then we are getting more information, okay? In this decision process, whether we should or should not proceed with RRP, my requirement, I don't want another rectal injury, because I've seen 4 of these in my career, and 2 of them ended up having a fistula. It's something that I don't think we should put patients through if I can avoid it. If I'm already there and if I inadvertently make it, unfortunately, it's too late for me. But if I can do anything to avoid it, then I would try. And these are our established goals. And we also want to do anatomical prostatectomy because this patient is already 70 years old. And as we all know, age is a big predictor of urinary incontinence, ED, everything else that goes on, including leak from an anastomosis. And once they leak, then the bladder neck contracture, if I can't see it properly. So in my mind, intraoperatively, what I realized was this patient has severe visceral adiposity. Which I did not know prior to surgery. Now, whether I could have done better knowing this, if I look back and reflect on it, so many x-rays, we look at MRIs and CAT scan. I don't know, I look at a CAT scan. Unless the BMI is 50, then I know I'm in trouble. But otherwise, the guy was 6 foot, the BMI of 35. To me, that's not necessarily a red flag for visceral adiposity. But I did realize when I got in there, it was a problem. I was proctoring a gynecologist once who operated with a BMI of 55, and he wanted me to help with a lymph node dissection. And I tried to identify the extraneous vein and the arcuate nerve. I didn't even know where I was. Obesity can be a huge problem. It was like operating on an elephant or something. It was a different species, and I got lost, so we backed up. There was another lady, I tried to do a lap nephrectomy. Her BMI was around 50. Initially, I had difficulty getting the ports in because the thing wouldn't go through. I tried to do a hand assist lap nephrectomy. And what I was doing was I was trying to make the fat incision to get a gel port in. I was actually buttonholing the skin and almost got out on another side of the skin rather than going into the abdomen, because the fat is so much that it's very difficult to get dissection. That patient had a renal vein thrombus. We did it open and she did fine. But just to tell you, this adiposity is not something trivial. Just to quickly get through this, in my mind, these things remain the same. Overall mortality, risk reduction, and so on. Urinary incontinence increases dramatically. I'm just going to put a number in here. This patient is guaranteed to see Dr. Costa because I don't think I can do as a good job. ED is guaranteed because he's already fat. It's guaranteed. And then the mortality risk is probably the same, but in my mind, the rectal injury goes up. Okay, so urethral injury is uncommon. I had only one urethral injury in a prostatectomy, but rectal injury can happen. It's much higher. I don't know the number, but I have every symptom: large prostate, difficult to retract. Now I got fat, I got bleeding, and therefore, in this particular situation, based on this method and this kind of logic, we felt it was better to back out. So I spoke to the family and she said, please, if you think there's any higher chance of making a hole in the rectum, don't do it. And she was very emphatic. And I spoke to the patient after the event. I meet them the week later to talk to them and make sure that they are on board with the decision we had to make on their behalf. And the patient felt very satisfied that we made the right decision. So in this case, we had a satisfied patient, but may not necessarily be the case every time. But that's just managing these patients. So I'm just going to quickly go through this. Intraoperative decision, unlike other situations, we are compelled to make difficult decisions.
Dr. Balaji, I have a question.
Yes.
If that patient was grade group 4, what would you do?
I would have struggled. It would have been a harder decision. I would have still backed out and given him ADT radiation. Because the problem is once the rectal injury happens, gets complicated. And then I've already spent an hour and a half Behçet. So if I spend another 6 hours on the table, I don't know how complex it's going to be. Now I've increased the operative time, and we all know anything more than 4 hours increases perioperative complications. So I think I would back out Behçet.
But radiation also has rectal injury. Radiation also for 100-gram prostate causes more lower urinary tract symptoms.
Yes, I agree with you. So ADT might help it. I agree with you, Behçet. Again, that's what my opening statement. You could argue either way, and that's fine. Ultimately, when you're operating and you're the attending, that's a decision you need to make. As I'm getting older and I'm seeing so many complications in my life, I've become very, very conservative. I was never ultra aggressive, but I was a pretty aggressive surgeon. I would take on, big masses, this and that. I've replaced aortas, vena cavas, you name it. I've done all that. As I'm getting older, I'm beginning to think, as we understand the data, heroism has very little role in surgery, and it affects our well-being. Once you have a complication, every surgeon has lived through it. It's a nightmare. Right? You don't sleep well, and you worry about your patients, and it affects your well-being, Behçet. So there's a lot of things that goes into it.
Thank you.
Yeah, I agree with you. There are so many ways to do it, and that's why I opened my statement, okay? And then, once you make a decision like we are doing today, and I really thank the residents giving me an opportunity. Otherwise, I wouldn't have looked at decision making the way I'm doing now. And always demonstrate humility. You're not here to impress anybody. You know deep inside your heart that we are all well trained. Every surgeon in this room is an expert in their own way. So we are not trying to prove anything to anybody, okay? We got to get out of that ego mode. Just say you're here to take good care of your patients and do the best you can. Be very